It's my pleasure introducing Dr. Amit Priyadarshi. He is one of the rare breed of shoulder surgeons and upper limb surgeons. So these days, there are so many orthopedic surgeons with knees and hips, ankles, everything. But you would rarely find a breed of upper limb surgeons. And he has been my senior. And fortunately, I am also in the same league as a shoulder surgeon. Welcome, sir, to this forum, and we are looking forward to your speech. And I'm looking forward to copying some slides from that. Please. Yes, yes.
So thank you very much. Thank you very much. This is audible, right? Thanks, Dr. Naman, for a wonderful introduction. Thanks to Soeaker and everybody here. So I think it's a privilege being here. Amazing forum to be here. So many super senior surgeons. I think I'm like a kiddie in the town. That's how I feel here. But anyway, so I might help your shoulders or patients which you have with a shoulder pain. So what I thought that I should tell you recent advances in the shoulder surgery. I believe that orthopedic surgery is not a new thing. It's it because you've been through all your colleagues, orthopedic colleagues, in your lifetime. I think my job is to tell you what recently what we see as an advancement in the shoulder surgery, not like what we used to do beforehand. So I think in shoulder surgery, you might be aware that we do rotator cuff repair surgery or bank cut surgery. I think these two surgeries have been there since long time, like many years, like 10, 15 years. But we are as a newcomers or getting few more experiences in the shoulder. We are investigating, we're researching. Me and Namal keep discussing things. So we are coming up with new things which has been growing through entire world, mostly in US and Europe, and we are kind of trying to bring those things over India and trying that in our Indian patients. So this is what I'm going to tell you in next 10 minutes. So I'm not going to bore you. I'm not going to spend a lot of time doing this chitty chatty, but I think certain thing which we should know. So myself again, Dr. Priyadarshni Amit from Amrita Hospital. So, as we know, these are common causes of shoulder pain in all the patients. Majority of patients would have these things as a shoulder pain. There are many other things possible in the shoulder, but these are the common things. So, although I think frozen shoulder is one of the common things which we tell all the patients. If one has got shoulder pain, we tell, okay, fine, you got frozen shoulder. But in my practice, in worldwide practice, frozen shoulder is just like 10% of the entire shoulder pain. So whatever we claim it as a frozen shoulder, that's not actually the frozen shoulder. So if you want to pick up one thing from my talk in next 10, 15 minutes, it's just one thing that please do not label every shoulder pain as a frozen shoulder, because real frozen shoulder is very less common in comparison to other diseases where you see mostly as a rotator cuff tear or rotator cuff disease. You might have impingement, you might have some tendinosis. You see an MRI for the patients, they will say some tendinosis, some intra-substance signal. That's not frozen shoulder. There's some problem with the rotator cuff. As it's very similar to as you age, your knee ages, your internal organs becomes old. In the same way, rotator cuff tendon becomes old, and that gives rise to pain, which is called rotator cuff disease, which may range from tendinosis, tendinopathy, mild alteration in the tendon consistency to the rotator cuff tear, where the patient will not be able to lift the arm up. If you ask him, say hello, he won't be able to do that. He will be able to do that. That's how the shoulder rotator cuff tear presents. Shoulder arthritis, although it's less common, but we do say this slightly more commonly in our practice compared to some 5-10 years ago. I have no idea whether the patient demographics has changed or we are become more expert in diagnosing shoulder arthritis. We have become more interested in arthritis because we now have a solution for shoulder arthritis. Maybe that's why we're seeing more and more of shoulder arthritis. Instability. Again, it's slightly less common as a reason for shoulder pain, but it's sometimes instability can lead to arthritis. Some of the instability, subtle instability, which might present as a pain rather than simple dislocation. So instability, I mean that shoulder dislocates in and out, in and out. Which patient say मेरा कंधा उतर गया था, आगे उतरा, पीछे उतरा, कहीं भी उतरा, लेकिन उतर गया था. So that subtle instability, subtle dislocation or subluxation can give rise to pain. And then of course our age-old favorite, frozen shoulder is a source of pain, but again less common. And then again, we sometimes debate whether the pain is coming from the neck region, like cervical spondylosis, that can refer the pain to the shoulder. So, I mean, if you see the patient with a shoulder pain, you can categorize most commonly the rotator cuff disease, shoulder arthritis, instability, frozen shoulder. That's how you can frame it. Now, recently, X-ray is not the one investigation we ask for shoulders. We have moved on from X-rays. We have gone to CT scan, and more so 3D CT scan. If you see my practice, majority of the patient will have MRI scan, but some of the patient, good bunch of those patients will have CT scan. I think Naman would agree with me that more and more frequently we are doing CT scan because we want to understand the bony anatomy. If the patient has a fracture, we need CT scan. If the patient has got instability, dislocation, we need CT scan. If the patient has got arthritis, we need CT scan. So CT scan is becoming one of more of our favorite tools in our practice to have, and especially 3D CT scan where we can frame it and assess the situation. Although this is less common, but I think we are getting into dynamic MRI scan. Now again, it's because we have got static MRI where the scans shows what the current structure is. But dynamic is like when you move the shoulder up and you see what structure is moving, which way it's moving, which is troubling it. So that thing you can do with a dynamic scan. Although it's not very common, but I hope that in next few years we all will have this dynamic MRI scan. I think no other talk can be possible without mentioning the AI. I think we are in the generation of AI, and as a shoulder surgeons, we do harvest some of the AI tools. Although not very commonly, but in certain patients, in the difficult patient, we do harvest this. AI is fantastic. We do our PPT presentation, not this one, of course, but some of the PPT you can make, some of the teachings you can make, you can record your voice, you can record your planning, you can do it later. So AI will help you with that. But when we are planning surgery, we don't know what the normal is. We just scan one side. We don't know how the other side is. We don't know what the other people's size would be. So what AI does is AI will take those data from the public and compare with your patient's data and give you the final result. That how is it different? If suppose I want to correct some orientation in the acromion, it will show me how much difference it is from the normal acromion of the population, and then it will tell you this the degree you should correct it surgically. So it's very handy in surgical planning. So coming back to our causes of shoulder pain. So rotator cuff tear, I think we all know about that. Rotator cuff is the tendon, are the tendons, four tendons, which is covering the shoulder as a cuff. That's why it's called rotator cuff, with the main function of to stabilize the shoulder so that your deltoid can work and lift arm up. You can have your good function. But unfortunately, with age, with time, it tears off. That brings pain. That brings pseudo paralysis. Patient will not be able to lift arm up. Regular activities will be very, very difficult. Historically, not very, very far away. I think 20, 30 years we came up with rotator cuff repair, and we do it arthroscopically. So keyhole surgery, you can say. Durbeen wali surgery. Patient love it. I love it. We all love it. Durbeen wali surgery. Again, it's a very easy one. Majority of the patient will have very good result after arthroscopic rotator cuff repair. You can do it within 1 hour or 1.5 hour, maximum in 2.5 hours in a big rotator cuff tear. You can see the lady is very happy, got her movement back. But not all the rotator cuff tear can be managed with a simple arthroscopic repair. Where this new kid in the town comes, graft patch. So you might have heard patch the shoulder patch. So whatever, when you are in difficulty, put a patch on the shoulder. So this is the patch we talk about. So if suppose certain individual, when the rotator cuff tendon quality is very bad, very poor, you take the bite, it tears off. It cannot hold those stitches, heavy stitches, sutures. Then to augment those rotator cuff tendons, we have this patch. Unfortunately, we have good number of companies which supply this out on the shelf patches. Unfortunately, it's very costly. 4 to 5 lakh is the average prices for these patches, but it improves the longevity of the rotator cuff repair surgery. And this picture shows how we put a patch on the shoulder. And this all things are done arthroscopically. So you don't need to open up the shoulder. With the tiny holes, you can put a patch, big patch inside the shoulder and suture it. For example, in this patient, that was a patient with a big rotator cuff tear with a very poor quality. And here's the patient after putting a patch on the shoulder, very nicely secured with all the stitches. Takes a bit of time, like roughly 2.5 hours to 3 hours. But at the end, you will have a very satisfactory function, like this lady who achieved very good abduction elevation within 6 weeks of surgery. So it's one of the things which gives confidence to the shoulder surgeon that I've done justice with the patient. Of course, it has some money in that. But in those patients where you can't repair, so patch I had shown where you can repair, but there is a chance of re-tear. It can tear off again. It can compromise your result. But in some patients, the tear is that big that you can't repair. You can't bring the tear. You can't bring the tendon back to its where it belongs. So what do you do? Without rotator cuff muscles, it's very difficult to get the function back. So what you do is you get some other tendon to do its work. So it's called tendon transfer. So you transfer one of the tendon to another place. I think pediatric orthopedic surgeons have been doing this tendon transfer for a long time for those CTE ways. Now we have taken that principle and put it on the shoulder. So what we do is we take another scapular muscle. So you got trapezius there on the top. You got latissimus dorsi on the back. So we take those tendons and put it on the shoulder so that it starts working. All the results are not very, very good as compared to normal repair, but patients are happy. They are able to get more than 90% of elevation. So they can do this, they can do your hair, they can do their hair, they can do their back scratching and all those activities. They can lift some weights also. So this is one of the things that we have started recently in maybe 5 to 7 years, and the results are not bad. They are good. This is one of the recent thing. We talk the patches, we talk of the tendon transfer, and then now we are going to put balloon in the shoulder. I mean, it sounds funny, but that's a real balloon, not with the air, but with the water inside. So what you do is you put a balloon in the shoulder, inflate it with a saline, that increases the space between humeral head and the acromion, so it increases the gap so that you can lift your shoulder up. So it's got a specific indication. Again, it's very, very expensive, so I believe 2 lakh near about. So, but in some patients, you can have this option also. Put a balloon in the shoulder. Now coming to second indication, second reason for our shoulder pain, that's shoulder arthritis. So Gissé-Pité shoulder joint, but fortunately it is less common than the knee osteoarthritis, which is more common in India. But we do see, as a shoulder surgeon in our practice, we do see 20 to 30% of patients coming with that bad X-ray, that it grinds, it cracks, it makes noises, it cannot lift, night pain, they're painful movement, they are not able to abduct, or they're not able to carry on weights. So that's a difficult situation. But this is what I love mostly in the shoulder surgery, shoulder replacements. There are types. You can have a total anatomical shoulder, and then you can reverse the shoulder. So reverse the shoulder means you got your ball and socket orientation, but you change that to a socket and ball. No other joints can be made like that. It's like dextrocardia. You put your right heart into left heart into right heart. This is what some crazy idea came up a couple of years back, and this is one of the most successful shoulder replacement now. Is reverse shoulder replacement. We just reverse it. It doesn't shoulder doesn't mind reversing. So this is what we do, and the patients are pretty happy. Patients are getting back in their 80s, in their 90s. They're getting back onto their even sports. They play golf after this. Unfortunately, with the recent advances, in a difficult scenario, we got planning software. If suppose the bones are too bad, you don't know where to put your implants in. Implants means all those metals in where you put your metal ball and sockets. So the software will guide you. You can play around like a video game. You can sit there 3 hours, play around where you want to have the best fixation, best of the implant position, and then you can guide them. So that's there. And there's just a small video to show how a shoulder surgery is being performed. Fortunately, we are not in. We do a good amount of good number of shoulder replacement now. Not as many as a knee replacement surgery, but people do it. I think in my practice, roughly once in a week, I'll be attempting to do this surgery, fortunately, and patients are pretty happy with that. So, basic idea is like you open up the shoulder, dislocate the shoulder, take the bones out, you cut the humerus on the side, and then you prepare the glenoid, you push the implant in, and in both sides, in the glenoid side, and then onto the humerus side. Just fast forward, it's a long video. And then you reduce it, check if you are stable, put a final implant in, and then that's it. Once you reduce it, and then after you do closer, and the patient will have good movement, stable shoulder function. But not every case comes up with a simple problem. They do have a bone loss in the humerus, bone loss in the glenoid, which is very difficult to reconstruct with the simple implants. And sometimes we do resort to this massive reconstruction where we are building up bones in the humerus with a mega prosthesis like a tumor prosthesis, or a bone taken from a cadaver bone, or sometime on the glenoid side, on the inside also you do have a customized processes which you order. It goes to the US, they build up a new one, they send it back to us, and then we implant it. So that's about shoulder arthritis. I think frozen shoulder, we all love it. Sometimes it's I think it's one of the severe pain which patients feel, and the classical thing is like they will be frozen. So name comes like frozen. Frozen is it's frozen. You can't move it, like frozen peas. You can't move it. A soft piece which is not frozen, you can press it. It has some elasticity. It has some movement. But a frozen shoulder is almost frozen. You can't rotate it. So a patient will be able to do this movement right from the scapulothoracic. But if you see glenohumeral, there won't be movement. It will be rigid, and that's what we call it the frozen shoulder. Not the painful shoulder is a frozen shoulder. It's a frozen is painful. Stiff shoulder is a frozen shoulder. Like this patient, I was trying to release this surgically, but again, I was not able to get inside the shoulder joint. It's that tight. But fortunately, after a good amount of surgical dissection, you can get a decent movement. You can have a almost full range of movement. But I think in those situations without a surgery, I think I would not be able to give her any movement, and she's fine now. So I think that's where I end. So thank you very much. Thank you for having me. Just to announce, I do come and see patients in Elysian Healthcare, which is nearby clinic. So if you got anything with the shoulder, elbow, upper limb, I'm more than happy to help them. So thank you very much.
Great.
Thank you.
Question after the end. Thank you. We'll have questions at the end of both the lecture. So you can join here. Next speaker is So our next speaker is Dr. Shikha Gupta. She is accomplished plastic surgeon. She has done MBBS, MS and MCH from KEM Hospital, Mumbai. And she got the first rank with gold medal in MCH plastic surgery.
Thank you.
From Maharashtra University. And after that, she did FRCS in plastic surgery from Royal College of Surgeons, Edinburgh. And also he got fellowship in microsurgery from Norfolk University, UK. And now she is working in Amrita Hospital as senior consultant and assistant professor in plastic surgery and reconstructive surgery department. She has a special interest in breast surgery, but today she will showcase all the cases of plastic surgery done in this hospital, not by only herself but by other plastic surgeons also. So Dr. Shikha, you can start your talk.
Thank you very much. It is truly a privilege to address such a distinguished gathering, and thank you everyone for such a warm welcome. It is truly very humbling for me because all of you are so senior, and it is like a privilege to be present here and presenting before all of you. And basically I would be Dr. Amit.
डॉक्टर अमित उनको थोड़ा हेल्प देखिए स्लाइड शो मत कर
I can't
स्लाइड शो
find
कर
it. I normally don't use
Dr. Shekhar,
keyboard.
this is more difficult than breast reconstruction.
I know. That sounds fine. At Amrita Hospital, we have a very dynamic team of plastic surgeons. So we all work in unison with each other, and we try to provide all services under one roof in the field of plastic surgery. So this is our team. So Dr. Mohit Sharma, he is the backbone of our department. He was a professor in plastic surgery at Amrita Hospital, Cochin. He's Safdarjung trained, and before moving to Delhi Amrita, he was working in Amrita Hospital, Cochin for almost 20 years. So, Dr. Anil Murarka, he is a very world-renowned craniofacial surgeon, and I will show you the kind of work he does. This is myself, Dr. Shikha, and then we have Dr. Dev Jyoti. He is a specialist in hand reconstruction and does a lot of brachial plexus surgeries as well. Dr. Vasundhara is a plastic surgeon with special interest in diabetic foot surgery. And we are all microvascular surgeons, so we do a lot of microvascular work. And Dr. Arun is a maxillofacial surgeon who is part of our team, and he helps us with all the fixations at the time of surgery. So, I'm really sorry, my presentation is going to consist of lot of clinical pictures and scenarios. So this is a 12-year-old girl who had a scalp avulsion injury. She was taken to a local hospital in Aligarh. So her scalp had got completely avulsed because her hair had got trapped in the chara cutting machine. So the local surgeon had just stitched up her scalp, and the family decided, no, we need to go to a bigger center. So they came to our center and we performed the scalp replant. So the whole scalp was positioned back to its place, and we did microvascular anastomosis. We had joined the vessels of the scalp to the preauricular superficial temporal vessels, and this is her result. And she's back to her normal life. She is going to school. Though it was a very challenging surgery for us, lasted for almost 12 hours because we had to join very small vessels under the microscope. So she's very happy now and has regained back her confidence. This is another patient who presented to us. He was visiting his friend's place and the ear was plucked off by his friend's pit bull. So he came to us with this. It was very challenging because this has been recorded under the microscope. The vessels were 0.5 millimeters, super microsurgery, and we joined back. However, there was congestion on day 1. So we took the patient back to theatre and redid the anastomosis and redid the vein anastomosis. And this is after revising the anastomosis. We injected heparin, we kept heparin soaks on the ear. So initially there were some changes of congestion at the edge, but overall shape of the ear was good. So this is the long-term result. He is very happy and he visits us quite often. So he has got his full ear back, whereas in another hospital he was told that he is going to live without an ear and will probably need artificial ear later on, or a formal full ear reconstruction. So we do a lot of digital replantations as well. So this is the patient. He presented with machine injury to his right thumb, and this thumb was complete. The tendon was avulsed at the origin. So we replanted his thumb. So we shortened the thumb because we like to do the primary anastomosis without taking any vein grafts. So joined the bone and followed by microvascular anastomosis. And this is how it looked after this 5 days after the surgery. This is the replant which we did very recently. He's an MB. He implanted it here in the temporal region, and that Borton's duct which drains the submandibular gland, was passed into the upper conjunctival fornix. So the patient's keratoconjunctivitis improved. He was able to produce tears. So it was very good. And this we have published as well. lot of burn wound managements. We do early excisions and grafting, and currently we are preparing for face transplantation. It hasn't been done in the country. We have the permission. We have done this is we are practicing on the cadavers, but we need the right recipient for it. So we have contacted lot of women's organizations for patients, burns patients who are who have deformed faces and who would want to go ahead with face transplantation. So Dr. Anil Morarka, he's our craniofacial surgeon. He's trained in Australia, Adelaide, and he does lot of craniofacial work, cleft lip palates, synostosis, cranial deformities. There's another spectacular case which I want to show you, hypertelorism. So this boy was born with this deformity. The surgery lasted for almost 30 hours. In unison, there were neurosurgeons, neuroanesthetists, pediatric neurosurgeon, and the patient was in ICU for almost a month. Lot of up and downs, but this was his result on table. And he's currently going to school, talking normally, has very normal IQ. So it's quite good. A lot of orthodontic facial trauma work. And obviously we do aesthetic surgery, breast reductions, breast augmentations, male breast gynecomastias. And this is Dr. Mohit shaking hands with, and
Thank
this
you,
is our
Dr.
team.
Sika, for I think wonderful cases. I think we, for many cases I also for first time. So thank you very much. You can join here.
Then you can come here. Right? You can come here. I think all of us feel like applauding the wonderful team and the wonderful work that they are doing. I think it's an eye-opener for many of us. I was listening to Dr. Supriya, and he said that I have a lot of friends in plastic surgery in Asia, and I don't think they are doing an iota of what these people are doing in America. So congratulations to you for doing all this. My first context setting will be from my moderators. I would request Dr. Naman Bahal to set the context for question and answer session to Dr. Amit.
Okay, thank you, Sushil sir, and thank you, Amit sir, for such a nice presentation on shoulders. Especially, you mentioned that frozen shoulder is not as common as people think, and we should not be labeling every painful shoulder as a frozen shoulder. I think that was one of the great takeaways from your presentation. But now I'll just open the session for questions. Sir.
Dr. Amit, a lot of time patient comes to us in our clinics, and especially diabetics, and we send them for MRIs and ultrasound, shoulder, etc., etc. They come back with the diagnosis of periarthritis. So, what is the right way of managing these patients, and when to refer these patients to you? Do you have the mic? No.
Yes.
You can take this.
So, periarthritis shoulder is not an MRI diagnosis. So, you cannot diagnose periarthritis by the MRI. It's a clinical diagnosis. So, if you are suspecting a periarthritis or a shoulder, a frozen shoulder, or adhesive capsulitis, it's a clinical diagnosis. Assess the patient clinically. If the patient has restricted rotations like external rotation or internal rotation, if this movement is restricted, that means that he has some component of stiffness in the shoulder, which could be primary frozen shoulder, or it could be secondary stiffness in relation to some other disease in the shoulder, which is most commonly is going to be a rotator cuff disease. So I think if you get periarthritis in the MRI, please ignore it. Don't look at it. Most of the time, you have to clinically examine and ascertain where is the problem. You have to differentiate between the different diagnoses. There is going to be cuff disease, or it's going to be impingement, or it's going to be any other disease. And thereafter, you take a call that what the patient is going to be. But if the patient is stiff, without doing anything, just send the patient for physiotherapy, ask him to do rotational exercises, your range of movement exercises. Let him gain some more movement. Because even if the patient has got rotator cuff tear, I'm not going to do anything for that unless until his stiffness is resolved. So stiffness takes a priority. So clinically, if you think the patient is stiff, send him to physiotherapy, let him gain the movement, and thereafter we'll deal with the rest.
Many times, Dr. Amit, we get an MRI report that there is a latissimus dorsi tear. So, if there is a tear in the latissimus dorsi, how do you manage them? Do all such patients do they deserve surgery, or they can be managed conservatively also?
So, lat dorsi tear is very rare, but I think most of the time the patient comes with a rotator cuff tear, supraspinatus tear, or infraspinatus tear, or subscapularis tear. Now, if the patient has got a rotator cuff tear, then please do not panic, because not all the patients with rotator cuff tear need surgery. So you can. I mean, if I am to scan your shoulders, I suspect like maybe 25% of you would have a rotator cuff tear in the shoulders. Even I might have some disease with a rotator cuff disease like thinness or some tendinosis, but I'm not needing any surgery. So always treat the patient, not the MRI. So ignore the MRI. MRI is like next step when you are struggling with the patients, when you have done physiotherapy, he's not improving, it's still painful, and you suspect something with the shoulder, then you get MRI scan. If suppose you have done already 2 months, 3 months of physiotherapy with no improvement, and the patient has got tear, which is symptomatic, which is causing him trouble in day-to-day life, which is causing him night pain, he's not able to live his life, there's no harm recommending him surgery. Surgery is a very easy one. Get him surgery, get him back on the track.
I would like to ask you as a question. There are a lot of people who keep coming to us, and we think that they are getting into not complete dislocation but subluxation of the shoulder joint. How to make a distinction between subluxation and complete dislocation of the shoulder joint in our clinics? Just a hint for our friends in their clinical settings.
So I think history is important. Dislocation, patient will be very clearly mentioning, मेरा कंधा उतर जाता है फिर चढ़ जाता है, उतर जाता है चढ़ जाता है. But in subluxation he will say, मुझे लगा कि उतरा लेकिन उतरा नहीं. I mean, he will say that मुझे लगा कि अंदर में कुछ movement हुई. And you should probe this. Did you feel like कुछ अंदर में movement हुआ? Like 2-3 times you have had it? And if the patient says yes, अंदर में कुछ लगा कि आगे पीछे हुआ है, most commonly it's going to be subluxation. Very rarely we do see tendon snapping over the pose. That's very rare. But most commonly it's going to be a subluxation of the joint. And please do not disregard that symptom. If the patient says मेरा कंधा आगे पीछे हो रहा है, मैंने कुछ किया, थोड़ा सा movement हुआ, examine the patient properly. And with the examination, you can ascertain the fact that his shoulder is unstable and that needs some attention of the shoulder surgeon.
Right. I would request Dr. S K Poddar to set the context for the second speaker, and then I'll go to everyone in the audience. Dr. Poddar, sir.
So, Dr. Sikha, wonderful cases.
Thank you, sir.
Not even hand you did.
एक बार ताली
So, this forearm transplantation, and how many? What is the golden period? Normally 5 hours, 6 hours. What will be the period, or can it be prolonged for 12 hours, 24 hours?
So normally what happens is whenever there is a donor available and the family brain dead donor available and the family is willing to donate the hands, the hospital informs the state, the regional or the state organ transplantation organization, SOTO or the
Noto.
yes, and then if there is and then to NOTO. So what happens is the area where the donation is happening, that region is preferred first for donation. If there are recipients in that area, if there's any hospital doing in that area, and if they have a recipient which is available and and the surgeon is available to do it and his PRA is negative, there are a lot of other factors, then the hand goes to that hospital or to that patient. And if then the NOTO sends a signal to everyone. There's a WhatsApp group and the NOTO notifies the centers which are doing hand transplantation that there's a donor available in Mumbai or in Gujarat somewhere. So if we have a recipient available with the same blood group, then we inform that we want to take this hand. Then they give us a time for retrieval. So the retrieval time is like 5 a.m. in the morning or 6 p.m. in the evening. So we get adequate amount of notice that there are certain hours available to us during which our team will go and sort of we will call the recipient to the hospital, prepare the recipient, and two members of our team along with the transplant coordinator, they go to the center where the donation is happening, which can be, most of the donations are from Gujarat and Surat, Baroda, and some are from Mumbai also. So the team flies to that hospital with all the equipment and our ice box, and we get the hand in the commercial flight. If it is an odd hour and the commercial flight is not available, like Mumbai, Delhi is not a problem, but Surat there are very limited flights. So we get a charter plane to get it. So we get adequate notice. So there is a certain amount of ischemia time. Normally in proximal arm we would prefer less ischemia time, but we push the University of Wisconsin solution. We have like a lot of other things, a lot of advancements going on, and a lot of research going on. There's an agent called Hemo2Life, which was sort of used in France, and we got one sample. We used it for one of our patients, which keeps the muscles and everything. Replants because it is like warm ischemia time and cold ischemia time. So cold ischemia time in distal replants can be as long as 12 hours. It is not a problem because the muscle bulk is very less. But in proximal we have done at 8 and 9 hours also. So our goal is, because it is cold ischemia time, so it is warm ischemia time is very less. It is like when you start preparing the structures. That too also we prepare on a table trolley which has like ice beneath it. So warm ischemia time is barely an hour. Barely an hour.
Thank you. I will ask other delegates to ask the question.
Ma'am, just wanted to know what is the approximate cost of a breast reconstructive surgery in your setup at Amrita?
Yeah, so we try and keep our rates as less as possible. So normally the cost of mastectomy along with axillary clearance or sentinel lymph node biopsy and reconstruction for a patient in economy ward, which is a 4-bedded ward, is around 4 lakhs. And in a private room, it amounts to almost 5 lakhs.
Ma'am, are they covered under any panels,
Yes.
CGHS, ECHS,
Yes,
etc.,
yes.
etc.?
Yes. So,
And does Ayushman apply to Amrita?
so Ayushman is there, but it doesn't cover breast reconstruction.
All right. Does it cover the hand and the distal
No.
reconstruction?
No,
it doesn't cover.
No, it doesn't cover. Ayushman doesn't cover. In fact, it is very sad that Ayushman doesn't cover most of the aspects of plastic surgery.
Right,
So we were initially putting lot of codes, but then the hospital was not getting paid from the government. So we have now even stopped putting like codes from other specialties.
Right, ma'am. Dr. Amit, you mentioned about changing the joint anatomy here at the shoulder, and probably it is called the reverse arthroplasty. So, how often do you do it, and what are the results?
So roughly once in a week. That's how I do it, and the results are great. In simple, they're great.
Results are good.
Pretty good actually. The patients who had struggled with weakness in the hand, they were struggling with pain, not able to lift their arm up in the air. They were not able to comb their hair. Night pain was there. Everything is gone. And did not have any complications so far.
Dr. Jitendra Saxena has a question. Dr. Jitendra Saxena was not there when I introduced you guys to everyone. He's a batchmate from 79.
Oh,
He
really?
is a wonderful general practitioner. He sees about 250 patients every day. His brother is a medical oncologist, Dr. V.K. Saxena, DM in oncology. His eldest brother is Dr. R.K. Saxena. He's a renal transplant surgeon. He is an alumnus of Cmes. He is in Chairperson Golden Hospital.
Wow.
Dr. Jitendra Saxena.
Thanks.
My question is to you. You must have heard of Ananya Bangla, have you? No. Sanjay Bangla used to be an ex-Indian cricketer.
Yes.
His son, and then later on moved on to become a daughter. He had sex affirming surgery. So Ananya Bangla is her name, and she's very famous on social media. She's a social media influencer. So she underwent this surgery, this genital affirmation surgery. She was
boy or whatever and she became a girl.
She became a girl.
Ananya Banga. I'm surprised nobody. No, I am. So, you do such surgeries there, and my second part is, I think it must be relatively simpler to convert a boy to a girl than the other way around. Is that true?
Uh,
Do such surgeries?
we do such surgeries, but
Very controversial
we
topic.
don't say no to any kind of patients who come to us. We can do any surgery, but somehow we are not getting many patients who want sex change surgeries. So recently we had a patient who was a boy and wanted to be a girl, and we did bilateral subcutaneous mastectomy. But I think the thing is that there are like dedicated centers where transgenders are going for sex change surgeries. So we do them. If the patients come to us, we'll not say no to them. And the other thing which you're asking is conversion of boy to girl or girl to boy. I think both are equally challenging or whatever. It is in a boy to girl we have to do breast augmentation, and in girl to boy we have to do mastectomy. Then obviously in boy to girl we have to do penile inversion, vaginoplasty. Yes, and then the other we have to do phallus reconstruction, which we are doing normally in all the patients. Either we are getting a lot of micropenis or post-traumatic amputations. We are doing penile reconstructions.
Thank you, ma'am. Anyone from there? Anybody? No. Ma'am, Dr. Mohanpreet, ma'am, she is an anesthetist at RMN Hospital, wife of Dr. Manavdeep Singh, my classmate, and ophthalmologist.
Ma'am, what is like the success rate of your this?
Transplantation. Ma'am, success rate is very good. The more distal it is, the earlier the recovery of function and the better is the result, as you could have seen also. In proximal level transplants, it takes a lot of time. We normally tell patients 1.5 years, but patients are able to become independent, especially in bilateral amputees. They gain independence in life. They're able to feed themselves. They're able to change their clothes, for which they needed help before.
Yeah, and they become sort of independent. I really appreciate that. But does it matter that the longevity of the surgery or the timing of the surgery or surgical expertise post-vector?
Ma'am, it is a multidisciplinary effort. We can't do it alone. We need a big team of plastic surgeons, anesthetists, because the anesthesia itself is so complex. Securing lines in these patients, giving them immunosuppression at the same time, and then we need our support of our orthopedic colleagues, then nephrologists. Our nephrology team is managing the entire immunosuppression. So they will regularly monitor the tacrolimus levels, the prednisolone doses, and patients follow up with them as well. So it is very complex procedure, which I feel should be done in like a big setup where there is a lot of support, and most important is post-op therapy. So patients should be willing to stay near the hospital and undergo post-op therapy, because if they don't take therapy, almost a year-long physiotherapy, supervised physiotherapy.
And is there any role of hypertonic oxygen therapy in these transplant patients? Have you ever tried that this flap stays, better preserved?
Ma'am, we haven't tried, but we might consider.
I would tell you to consider.
Yes, ma'am.
Because, many times the surgical flaps which are dwindling have survived because of the hyperbaric oxygen. I wanted to add this.
Yeah, thank you so much, ma'am, for your suggestion.
Dr. Pawan Chaudhary, he is a neurosurgeon at Balaji Action, and also with Dr. Bajaj is something. He has a question.
Excellent work, ma'am.
Thank you.
All in the hospital.
Thank you.
My concern is the neurosurgery that we get a lot of facility invitation, and a few of them were unfortunately once done on the patient.
Yes.
So, simple question: what is the success rate of these patients? We are going to go ahead. And does this success rate depend upon the grade of paralysis, complete paralysis or partial paralysis?
So we have, yes. Thank you very much for your question. So basically we have, so for partial paralysis, our surgical approach is different, and for complete paralysis, it is different. For partial paralysis, it depends upon what the patient desires. So if he is able to smile but it is weak, then we might do a sling operation just to give him some facial symmetry as compared to the opposite side, and we teach them how to sort of cognitive behavioral therapy is given at the same time. But in complete paralysis, if there's early presentation, we prefer to do nerve transfers. So we do masseteric nerve to facial nerve transfer, and that has very good result. Patients presenting within 1 year after surgery. And in patients who are presenting like more than 1 year after surgery who've had previous radiotherapy, we prefer to do muscle transfer procedures, and they have very good results. Earlier we used to do first two-stage procedure in which we used to do cross-face nerve graft in the first stage from the opposite side using a sural nerve graft, and then in the second stage we used to wait for the nerve to regenerate from hair to hair, and then we used to do free functioning muscle transfer using gracilis. But now we do like a single stage transfer, so we do like a dual nerve innervation of the transplanted muscle. We do the nerve anastomosis to the masseter nerve, and at the same time we do cross-face nerve graft. So patient has both the dynamic smile and the emotional smile. So it has really good results. And for the eye, we do temporalis transfer. Only in patients who have lot of comorbidities, because the procedure of free functioning transfer is a long procedure. So patients who have lot of comorbidities cannot withstand long surgery, then we do like a temporalis transfer, which itself also has very good results. Thank
Dr.
you.
Mandeep from RMS Hospital, ophthalmologist, he has a question.
When Corona came and vaccine, actually in our hospital, vaccine was being given. Actually, it's a question for Dr. Amit. When third dose of vaccine was given, I got a lot of pain in that shoulder, which lasted for almost a year, and for 7 months I was continuously on chemotherapy. When I used to visit our chemotherapy department, I realized there was a large number of people who suffered a similar problem following third dose of vaccine. Any comments or any experiences?
So, I think we had few reports actually, published in international journals that post-COVID vaccination there was some hike in frozen shoulder, like shoulder pain and stiffness incidence, and this well validated. So you're right. That time, exact correlation we could not make out why did this happen, but incidence-wise there was a couple of patients who presented with a shoulder pain after COVID vaccination. But that was not long lasting. I think the report said that it kind of recovered in few months, but it took few months. I guess you must have recovered by now. So we can't say exactly what was the correlation, why did this happen, but there was some correlation definite.
Right, on dinner, Dr. JPS Murthy.
So, great talk, Dr. Amit. So,
Thank you, sir.
let me take you back to the rotator cuff injuries. So, when is surgical intervention needed? We know at least 80% of the partial tears of rotator cuff injury would probably heal in about 6 months to 12 months time. So, when do you need? Is it for complete complex tears that you need surgical intervention?
So I would just correct that the rotator cuff tendon when torn, it never heals. It's always torn. Once torn, always torn.
Partial tears.
It always torn. It doesn't heal on its own. The few MRI picture will show that it's healed, but I would start questioning that MRI report. I have
See,
to.
so many patients having partial tears and having healed.
Clinically, they are better. Their pain is better with the help of exercises.
Completely pain gone in
Yes,
about
yes,
6
yes,
months'
yes.
time. You don't have to surgically intervene here.
Yes.
Only the complex full tears probably need surgical intervention. 80% of the tears, partial tears, heal of its own. I will know you are the master.
So,
Tell us.
I would leave the MRI picture of those stairs, but majority of the rotator cuff tendon, even if it's completely torn, they don't cause trouble after some time. You rehabilitate them well. You do give injections. You do a proper physiotherapy, rehabilitation. They tend to stop causing you symptoms, and that's a very good percentage, almost like 80-90% you can say. So out of like 100 patients, if I see those patients in the clinic, I think my rotator cuff repair surgery is almost 10% of them. Not everyone needs surgery. So with a very good rehab, so I think more than me, the physiotherapist has to be good in rehabilitating those patients. They have to target those proper muscles. And when they counterbalance, then the patients are okay. But there are certain individuals that we do not leave, like young patients with a tear. A young patient, 30, 40, maybe 40 or 45 years old, who is still dependent on his shoulder. Because what I feel like when you rehabilitate them, their pain gets better, their strength doesn't come back to their previous strength. So if it was me, I would love my strength to be back. I want to lift things up because I've got a young kid in my house. I want to play with them. I want to go and play cricket. So those are strength I need. I can play golf, but if I'm doing something heavy, I won't be able to. I won't be able to carry luggage. So in those patients, I would not shy away from recommending them surgery. That you are young, you need your shoulder strength. I can probably bring your pain under control with the help of exercise or injections. But to give you strength and proper function, you do need surgery. So I think it's patient specific. So not everybody. I mean, I can't generalize things. It's like patient specific. Suppose it's like 70 years old man, but he's very active. He loves playing golf. He loves playing cricket. He loves playing badminton. I mean, am I going to leave his rotator cuff tear and get him to the stage that his shoulder goes on arthritis when his other shoulder has already gone arthritic? I would rather repair him. So it's like individual basis I make judgment.
Talk us a little about the revolutionary reverse shoulder replacement needed in severe arthritis and in irreparable rotator cuff injuries. Talk us about this.
So reverse shoulder replacement is one of the bailout option for us actually. I mean, I would say when you can't do anything, just reverse it. It tends to work in majority of the problems. Like in arthritis, yes, it works. Severe arthritis.
And irreparable shoulder
Yes.
cuff. Yeah.
So in severe arthritis, it works. In irreparable rotator cuff tear, it works. In tumor, it works. In fracture, it works. So it tends to work in almost everything. But again, in an irreparable cuff tear, I do not always advise reverse shoulder replacement because if something is like the downside of the reverse shoulder replacement, it's not going to last forever. It's got a life. It's because it's implant. It's man-made implant. It's not the natural tissue. It's going to live for like 15, 20 years maximum. And after that, we're looking at replacement, revision replacement. So one revision replacement is okay. Two at the max are okay. But third revision, we're not going to left with any bone. So I think in less than 60 years or 50 years, I would still be inclined not to recommend reverse shoulder replacement if I have got other option of reconstruction, like capsular reconstruction or a tendon reconstruction. If I can do those things, I can delay the reverse shoulder replacement. I'd rather do that than reverse shoulder.
Dr. Sika, ma'am, I think